Hello, everyone. My name is Dr. Casey Patrick. I am the Assistant Medical Director for Montgomery County Hospital District EMS located in Greater Houston. We're a ground-based 911 EMS service serving approximately 1,100 square miles. I'd like to talk to you today about our abstract entitled Treatment of Hyperkalemia in the Pre-Hospital Setting. A little background before we get into the data nuts and bolts. This hyperkalemia treatment protocol was 100% paramedic driven. 5 or 6 cases came across my desk, across Dr. Dixon's desk several years ago, which illustrated the need for its existence. Astute, forward-thinking medics brought us patients who had missed dialysis, patients with severe DKA, awake with bradycardia, potentially hypotension, and the medics recognized classic hyperkalemia EKG changes as well and said, hey, docs, we can't treat these folks until they go into cardiac arrest. This prodded us to write a protocol for presumed hyperkalemia treatment in the field. So in the abstract, we look back at the first 3 years of the protocol's existence and the 49 non-cardiac arrest patients that were treated for presumptive hyperkalemia within our system by our paramedics. You're going to ask yourself, well, how did you determine who you could treat and how you recognize those patients to initiate them within the protocol? And we taught our medics that they had to cross 2 hurdles before treating patients for hyperkalemia. First, the patients had to have clinical risk factors for hyperkalemia. Those included end-stage renal disease or DKA or rhabdo/crush injury. Then, if they had high-risk clinical features, they also had to have high-risk EKG features, defined as peak T waves or widened QRS or bizarre bradycardias with wide QRS. Calcium chloride, nebulized albuterol, and sodium bicarbonate were all available at paramedic discretion for treatment. Our data was abstracted from our EMS electronic records along with our receiving ED electronic medical records as well. The patients in this study group had a median age of approximately 62. They were predominantly white with a slight male predominance. Medical history, over half the patients qualified via end-stage renal disease, almost 40% had diabetes or DKA, and a smaller fraction with rhabdo/crush injury. Almost 90% received calcium, almost 80% received sodium bicarbonate, and approximately half received nebulized albuterol. This number is falsely low, secondary to albuterol being removed from the truck due to aerosol generation concerns, as a large portion of the study period overlapped the COVID-19 pandemic. When looking at the results, what questions did we ask? We asked, number one, could our paramedics accurately include appropriate patients by the protocol definitions? And encouragingly, we found that the protocol was applied appropriately in 44 of 49 patients. 90% were appropriate. We looked back at the narrative. Independent reviewers looked at the narratives to say, did they have clinical risk factors as described? Yes or no? If the answer was yes, then did the EKG via EMS also show classic hyperkalemia EKG changes? And if so, the administration and the inclusion in the protocol was deemed appropriate. Secondly, we asked ourselves, out of the appropriately targeted patients, how many of those were actually hyperkalemic, defined as greater than 5 milliequivalents per deciliter upon ED arrival lab work. And of those deemed appropriate, only 52%, or 23 of 44, were actually hyperkalemic upon arrival to the ED. This is not shocking, as emergency department data basically states the same thing, in that EKG findings are not terribly accurate for truly identifying hyperkalemia in the ED setting either. Did we cause any harm? No episodes of cardiac arrest occurred during transport. No significant bradyarrhythmias or tachyarrhythmias were noted following treatment. We did, however, have one patient, or 2% of the patient population, present to the ED with hypokalemia. The level was 2.9 milliequivalents per deciliter in that patient. So what are our conclusions and where do we need to go in the future? Encouragingly, we believe paramedics can recognize hyperkalemic EKG changes, those classically taught, and appropriately identify high-risk hyperkalemic patients in the field. Pre-hospital hyperkalemia treatment in awake patients appears to be safe, with only one mild hypokalemic patient noted in the study period. However, this data confirms what is known from ED data, and that is that EKG findings alone are not terribly accurate in determining true hyperkalemia. So in the future, we would like to try to refine our inclusion criteria to more accurately identify true hyperkalemia in the pre-hospital setting. We obviously need larger sets, a larger patient population to continue to refine this protocol and improve its safety profile. I'd be remiss if I did not thank the folks in the background that made this protocol and this study happen. Brad Ward is our cardiac coordinator at MCHD, who did a majority of the preparation and the data abstraction for this abstract. Zubayd Rafiq is on staff at Baylor College of Medicine, Department of Emergency Medicine in Houston, and lent his significant hyperkalemia expertise. Luis Rodriguez is a former Baylor emergency medicine resident who helped significantly with background work as well. And I would not be talking to you without the encouragement and support from my medical director, Dr. Rob Dixon, and the administration at MCHD as well. If you have questions about protocol specifics, about study specifics, about any additional thoughts or concerns, please do not hesitate to email us. We'd be happy to answer any questions and to talk further. Thank you and have a great conference.